Welcome, everybody. Usually in January, I commend people for making it out despite the winter weather, but it feels a little more like March or April out there, so you get no bonus points for attending. But nevertheless, this is an immensely exciting topic. I'm unsurprised that the room is full, although if people are looking for seats, there's still a few up in the front. Black box medicine has enormous potential to shape healthcare for the better by improving and aiding many medical tasks. What we're talking about in black box medicine are machine learning algorithms and artificial intelligence, which examine a variety of different healthcare data sources, including genomic sequencing, patient records, and the result of diagnostic tests to make predictions and recommendations about care. An algorithm is called black box because either it is based on unknowable machine learning techniques or because the relationships that it draws are too complex for explicit understanding. Now, that elicits a knee-jerk reaction, I think, in most people. Certainly it does in myself, probably in you as well. And so one of the big questions confronting us when we look at the use of this tool is it that we don't like the fact that we can't check the machine's work because there's something inherently wrong or problematic about that? Or is it just discomfort with a new technology that we will get over? Certainly the stakes are high for figuring out black box medicine and other applications of artificial intelligence in healthcare. We've made significant progress in areas such as radiology and oncology, and tech can't solve everything, but it can help extend our limited resources to make better use of healthcare spending. So, for example, IBM Watson for Oncology is a machine learning system that intends to help clinicians quickly identify essential information in patients' medical records and explore treatment options for 13 different types of cancer. And this is good because we only have limited human hours, and so the machines can make our physicians, our practitioners, more effective. But there are serious concerns into incorporating AI into healthcare, which our speakers will address and unpack. Some of them are that the algorithms are really only as good as the data that they are fed. And our data sources, like most things in our society, reflect some inherent biases. So recently I was talking to somebody who is building AI for breast cancer detection, and she was telling me about a popular algorithm that is in use that in African American women is actually worse than random at predicting what the ideal treatment should be. When she asked the creator, why is it worse than random in this population, he said, well, this algorithm was created for white British women, not for African American women. It's a different population, it's different data. So the algorithm really would need to be retrained on this data. It can also reflect other inherent biases, such as ones around disability. How do we tell the algorithm to value people who are differently abled when in society we sometimes struggle to do that ourselves? Then there's the question of how great the data is. Watson for Oncology famously has been using synthetic data, which has been very controversial, and people have suggested that the results of Watson for Oncology are not optimal or should not even be used because the algorithm was trained on synthetic data. These questions are only going to get even more challenging as we move away from the initial easy applications, such as radiology and oncology, into more and more difficult applications. There's also the question of how should clinicians incorporate AI and black box medicine into their practice. Right now, we consider these tools to really be decision aids. They don't tell physicians what they should do, but they suggest, hey, maybe you want to give this patient a CT scan instead of an ultrasound or vice versa. But very quickly, we're going to get to the point where these tools are not going to be decision aids, but decision makers. How do we train physicians to weigh these tools appropriately? What do we do when the AI recommends something different than what a physician with years of experience would do? And how do we train the next generation of physicians who are going to come of age with these tools and techniques firmly embedded into their practice? Before I introduce our speakers, I want to say if today's topic is interesting to you, then you should check out our project on precision medicine, artificial intelligence, and the law that we host here at the Petrie-Flom Center. PMAIL, as we like to call it, is a comparative analysis of the laws and regulations and incentives around black box and more broadly artificial intelligence in healthcare, both in the US and in the European Union. We're trying to answer some of the questions that I flagged and other questions such as exactly where does the liability lie when we have broadly implemented AI. So please keep your eyes open for further things coming out of PMAIL, as well as other events, publications, and reach out if you find this particularly interesting. Now, in my initial presentation, I've flagged a whole bunch of interesting but difficult to answer questions, and as the moderator, I have the luxury of not needing to answer a single question. Instead, the two people who will hopefully tackle these questions and provide some answers, or at least suggest how we should be thinking about answering these questions, have joined me on the dais. So first up will be Professor Glenn Cohen. Glenn, I have not memorized your bio, although at this point I probably should have, but he is the James A. Attwood and Leslie Williams Professor of Law at Harvard Law School, as well as the faculty director of the Petrie-Flom Center. He's the author of more than 100 articles and chapters, and his award-winning work has appeared in a variety of venues, from legal, including the Stanford, Cornell, and Southern California Law Reviews, medical, including the New England Journal of Medicine and JAMA, and bioethics, including the American Journal of Bioethics and the Hastings Center Report, not to mention scientific, such as Cell and Nature, and public health, such as the American Journal of Public Health. He's also the author, co-author, and editor, or co-editor of 12 books. Joining him is Zayed Obermeyer, who is a physician and researcher who works at the intersection of machine learning and health. His research seeks to understand and improve decision-making in public policy and clinical medicine and drive innovations in healthcare research. His work has been published in Science, the New England Journal of Medicine, JAMA, the British Medical Journal, and Health Affairs. He is the recipient of an Early Independence Award from the Office of the Director of the National Institutes of Health and the Young Investigator Award from the Society for Academic Emergency Medicine. His research is supported by the National Institutes of Health, the Robert Wood Johnson Foundation, the World Bank, and the Laura and John Arnold Foundation. So please join me in welcoming our two speakers.
Sorry. I'm going to start with a joke I've told before, which is there's so much hype in this area. People talk about big data, machine learning, the way adolescent boys talk about sex in the locker room. Everybody says they're doing it, and they say that they're doing it all the time, but the truth of the matter is many of them don't quite understand what it is. If they are doing it, they're doing it not very well, and certainly in not a way that both parties to the interaction enjoy or benefit from. So we want to try to cut beyond the hype. But to start, I'm not going to be promoting any unlabeled, unapproved uses of drugs, devices, et cetera, et cetera. So I thought we should start with a little bit of vocabulary. Big data has become the ubiquitous watchword of our generation. What does it actually mean? It's thought to have at least 3 V's to it. The first is volume, vast amounts of data. The second is variety, significant heterogeneity in the data. So genetic results, patient records, maybe even shopping habits. The third is velocity, the ability to process the information at an incredibly rapid speed. And the fourth, which is sometimes there and sometimes not, it's aspirational, is value. It's going to add value to the way we do healthcare. Predictive analytics is something we want to do with big data. It's the use of electronic algorithms that forecast future events in real time. And it's intersecting with the law in a myriad way, from how votes are counted and how voter rolls are revisited, how to target taxpayers for auditing. But we're mostly interested today in the healthcare implications. Much of the care we have today in America and around the world remains relatively untracked and underanalyzed. We don't know that most of the treatments we give are effective. Many prove to be ineffective. We don't know what works and what doesn't work. Big data can help. We can leverage patient records, patient data, including record data outside of the healthcare encounter, with the idea of improving patient care. This can be used in terms of improving actual techniques we use, in terms of pharmacovigilance, in terms of trying to figure out what products should be taken off the market, ... Machine learning is a subset of artificial intelligence. It's a method of data analysis that attempts to find structure or a pattern within a data set without human intervention. And we usually classify machine learning algorithms into supervised and unsupervised algorithms. In supervised learning, the system is presented with example inputs along with the desired outputs, and the system tries to derive a general rule that maps one onto the other. So for example, the identification of diagnoses by symptoms. In contrast, in unsupervised machine learning, no desired outputs are given and the system is left to find patterns independently. For example, clustering and anomaly detection. One more distinction vocabulary-wise to raise before we jump into the legal and ethical issues, and that is the notion of a centaur. You might say, wait a second, that's classics, that's Greek mythology, why are you talking about centaurs? You'll remember that the centaur is a hybrid of human and horse. The future of AI is unlikely to be systems running autonomously, but instead the partnering of human ingenuity and human knowledge using AI systems much like the centaurs. Because it turns out, as we know from examples from chess and Go and the like, while AI systems often beat humans, humans plus AI often beat merely AI. So the goal we're striving towards for the most part are these kinds of centaurs. Okay. Let me start with some sunshine, which is current and near future applications. These are just a couple of examples. In 2017, FDA approved Arteris's medical imaging cloud AI as the first machine learning application that could be used in a clinical setting. Originally approved for cardiac images, but it's also gotten FDA clearance for oncology imaging. And the company's new clinical offerings include lung AI and liver AI to help radiologists quickly measure and track tumors or potential cancer through MRI and CT scans. Research from Stanford, published in Nature, I think now it's a couple years ago, on AI that was trained to classify images of skin lesions, recognizing over 2,000 diseases. Another example up here is IDXDR, the first AI diagnostic that provides a screening decision that can be used without the oversight of a clinician to interpret the image or result. It's an AI-based device. It got FDA approval in April 2018 to detect the eye disease diabetic retinopathy in diabetic patients. Recently, researchers from Moorfields Eye Hospital in London and other people, including DeepMind, published in Nature Medicine a study showing that the AI system can read complex eye scans and make referral recommendations comprising more than 50 diagnoses. And the system was trained on 14,884 scans and showed a success rate of 94%. In reality, the future, I think, can be divided in two columns. Two ways of dividing the world, although I'm always cognizant of that Tom Robbins quote that there are two types of people in the world. Those who think that there are two types and those who know better. So I don't want to suggest that this is exhaustive, but I do want to suggest this is perhaps helpful. One is by function. Where do we see AI being used? Imaging has been the low-hanging fruit. We have tons of data. It's easily machine readable. But in the future, we'll see more prognostics, predicting what health needs will be for particular patients in the future. Diagnostics, determining what is wrong with a particular patient who has symptoms. And treatment, using AI to suggest which among a set of possible treatment possibilities will be most successful. But a different and complementary way of thinking about this is related to the purpose. Why are we turning to AI? One of the most important contributions will be the democratization of expertise. Everybody could get access to a good dermatologist through the AI, rather waiting for a specialist referral, or perhaps in a developing country, not having specialists available to large swaths of the population. They might be able to automate drudgery. Who wants to do their billing as a dermatologist? Let's free up the time the dermatologist spends on that by having the AI handle the drudgery part of the work. Optimize resource. Choose who among a patient population sees the dermatologist with priority. Do triage. And finally, pushing frontiers. Improving how dermatologists perform their jobs, computer-aided dermatology. Now, most of the public discussion of AI focuses on that last category, pushing frontiers. But most of at least the short and middle term value proposition is actually going to be in the other categories. So let me just make this tangible with two use cases very briefly. One, based loosely on Watson for oncology, is a decision of what therapeutic to apply. So imagine you're trying to decide which of a set of cancer chemotherapeutics to apply. You look at your patient's EHR record, and built into that is a module that helps you make some decisions. It uses not only the information of the EHR, not only genetic sequencing of the patient and of the tumor, but also links up to consumer data about that patient's shopping habits, location, age, demography, and compares it to the same records for millions of other patients who have been de-identified into the system. That is where we are rapidly going towards. Perhaps a slightly more far-flung but also ethically interesting question would be, instead, imagine you're trying to determine who to admit to the ICU. You could do a workup. It would take you several hours. It would have relatively limited inter-rater reliability, but you could do that. Imagine instead you had a system that could do it continuously every 7 minutes for every patient in the hospital who is eligible for the ICU to help you make immediate decisions constantly being updated. Now this one is interesting because the AI is not only telling us which of several therapeutics to give, but also helping us decide how to prioritize between patients. This is where we want to go. Okay, so that's the sunshine. Now I'm an ethicist and a lawyer. Let me bring you to the clouds. This is my master slide of all the ethical and legal issues you're going to face in trying to do this. And this is a little bit like me. I'm looking at Ziad for a moment because he actually does this stuff. This is like a philosopher talking to their mechanic about how they should think about the engine, right? The zen of the engine, right? So I agree with that. That's totally fine. He'll tell you how they actually do it. But I'm going to tell you how we should conceptualize this from a legal and ethical perspective. Phase one, where do you get the data from? How do you acquire the data? Among the issues, do patients like you and I have to consent to the use of our EHR data for these purposes? Is that enough to sign a front door consent that none of us read when we enter the hospital for the first time? Or does there have to be a more specific consent? Is it enough to consent for all purposes, or does there have to be details about the purposes they want to put the data to? Do I have to be re-consented for that? Is notice enough? How representative is the data set that's going to be involved? Does it represent only the patients that go to the Brigham and Women's Hospital, or does it represent patients from all over America? Ziad's going to spend considerable time talking about the problem of bias here and the extent to which statistical corrections can be made on the back end. If they can't be, how do we incentivize better, more robust, more diverse data collection? What role for patients in this governance of this data? Should patients be empowered to make these decisions, if not at an individual level, at a collective level? Is the right way to think about this like a union, or maybe like a trust, like a will with fiduciary duties? Okay, you've got your data. Now you're building and validating your model. How do you know your model is good enough to actually be used on real patients? What is the standards of validation that we put in place? Are we going to have risk classification where we're going to have more rigorous, robust classification for higher risk use of algorithms versus lower? And who's going to be doing that classification? Here we have a real tension between transparency on the one hand and trade secrets on the other. In an ideal world, as patients and as regulators, we want the data, we want the training data and also the algorithms to be as transparent as possible so that anybody can go under the hood. But in a world like in the US and the EU, where the algorithms are not themselves patent protected, most companies will turn to trade secrecy as an intellectual property strategy to protect their investment. Trade secrecy is very difficult to reconcile with accountability, auditing, and transparency. Can we do this? Are we going to look to third-party auditing under contractual sort of arrangements? Is that the solution here? And what kind of agency is going to be empowered to do this? FDA has traditionally been very allergic to software. It's something they don't touch, and very allergic to the practice of medicine. It's something they say they're not about. Is this going to force an agency like FDA to get into those areas, and will they be successful? Phase three, you've got a validated algorithm based on patient data, and you want to test it in the real world. Do you as a patient have a right to be told that your care is being informed by or maybe partially directed by an AI? Is that part of what we expect in the informed consent process? Can patients opt out? Does it matter whether the opting out is about a resource allocation question as opposed to a treatment recommendation? What about when the AI is actually directing the way the hospital is staffed? How often to send a physician versus a physician's aide around? How quickly to process certain kinds of test results? Are those the kinds of things that we think patients have a right to know? Most patients currently know zero about how those decisions are being made. Is it different because an AI involved, or are we guilty of a kind of AI exceptionalism here? We'll discuss in a moment the questions about liability. Who pays for what when something goes wrong, as it will? There are also difficult questions about model implementation versus model design, questions about choice architecture. So for example, how many alerts, how many overrides are necessary, and how do we configure the item this way? Once again, what regulator or combination of regulators is best suited to do this kind of work? Phase 4. You've got a model, it actually works in real patients and is showing improvements. Now you want to engage in broad dissemination. But there's a problem. This might cost money. Will hospitals pay for this? Will insurers pay for this? Will the government pay for this? Is there an obligation, if these models are based on the data of patients all across America, to have the model be available to patients all across America? And how do you achieve that? Are there obligations towards graduated licensing? So I want to just delve into one or two more of these in greater depth, and then I'm going to wrap up. The first is the question about safety and effectiveness. As Carmel alluded to, Memorial Sloan Kettering has given a little bit, and Watson Oncology more specifically, I should say here, has given some people some cause for concern based on the Watson for Oncology and the way it was implemented, and this question of synthetic controls. And something I think we should talk about during the Q&A, if Ziad's not going to talk about it in his own slides, is the question about whether using synthetic cases makes sense here as opposed to real cases from training data. But this example shows us that there's a real possibility that something is going to go wrong. When something goes wrong, who pays for it? There's a few possible model designs here. We've got malpractice, that's what we use currently with doctors. But in fact, the current liability regime says if you are a physician that relies on a computer decision aid, and the computer decision aid has the error, you nonetheless pay for it. You pay the bill. Is that problematic in a world where physicians not only rely on these these AI medical devices, but can't understand them because they are based on largely black box model? Should we be thinking about moving to something like a vaccine compensation fund, which pays out regardless of fault? Or should we have a system of pre-clearance by an agency like FDA, the idea being once you achieve that kind of clearance, you are immunized for liability? How do we allocate liability between the makers of algorithms, the hospitals that purchase them, the physicians who rely on them, and the insurers who pay for them? Okay, and this is my last slide, privacy. In the US, as opposed to Europe, we have relied on a system of privacy protection that is custodian and sectoral specific. HIPAA, which many health professionals think is actually a four-letter word, right, is our main statute that protects health privacy here. But it protects covered entities and their business associates and only certain kinds of data. We are rapidly getting to a future where most of the data that's going to allow us to make inferences about your health and my health is not above the waterline. It's not the stuff generated by your visit to the doctor, but all the stuff below the waterline. Your purchasing habits at Target, your Fitbit results, your social media, how you spend your time, your Google searches, right? Turns out there's some interesting studies showing that Instagram filter choice are excellent predictors of depression, for example. In a world where it turns out our statutes and our whole scheme is focused on what's above the waterline, what happens to all that data below the waterline and how do we regulate it? So with that, I'm going to turn it over to my friend, Dr. Obermeyer, and thank you very much, and thank you to the funders.
Thanks so much for having me. I want to start off with a thought experiment for you guys. So imagine that the FDA has approved a new technology. Imagine that this technology is made by a large multi-billion-dollar for-profit company. And doctors all around the country, after it's approved, just start using it overnight. And we don't really think they have much of a clue on how it works. But it's starting to affect the lives of millions of people. And we actually have no idea, whether we're doctors or policymakers or patients, how this thing works. And I think that's a very concerning scenario to most people, with good reason. But I'll tell you one odd thing about this thought experiment, is that this thought experiment describes many, many drugs that are in use today. So we have very little idea how most antidepressants work, how statins might work to prevent heart disease, how metformin works to reduce the risk of diabetic complications. It also, for those of you who took Tylenol earlier today, describes how we think about Tylenol, which is that we literally have no idea how it works. And if you start looking at all of medicine through the eyes of like, oh, do we really understand this? When you go get an MRI of your knee, how well versed do you think your doctor is in quantum physics? Do you think they really understand the Lorentz forces and the spin dynamics of different tissue? No. And I think if you, again, follow this line of reasoning, this sounds completely insane, right? This sounds like a crazy situation, that all around us in our medical system, we're just surrounded by black boxes. So it does sound crazy. And I think what I'll try to convince you of in the next few minutes is that it's not so crazy, and that in fact, we do not need to open these black boxes to make very profitable use of them in society and in medicine. The key point is that we can actually, without opening the box, look at the inputs to the box and look at the outputs of the box. And for drugs, we do this all the time. Even for drugs whose mechanisms we don't understand, we can put them through randomized trials and look at the health benefits that they do or do not generate. What would that look like for algorithms? I think a good starting point would also be randomized trials of algorithms compared to usual care. It's not a bad start. But since that's not being done, and since many algorithms are actually out of the box already and being used in society, there are some other methods that we can bring to bear. And those are generally categorized as audits of algorithmic outputs. And so what I want to do for the next few minutes is just take you through a concrete example of one of these things, because I think it's sometimes easier to engage with some concrete examples than with abstract ones. And so we're going to consider an algorithm that's actually in wide use today, that's affecting tens of millions of patients around the world, and the healthcare decisions that are being made for them as we speak. And I'll just make a broader point that, Glenn mentioned a lot of areas in medicine where people are very optimistic about what algorithms are going to be doing. In a lot of healthcare delivery settings, in accountable care organizations and Medicare Advantage plans, algorithms are already being used at scale today. And I think this is very unlike the promise of AI. This is actually happening now. And we have very little understanding of how these things are working. So that's why there's some urgency in figuring out how we deal with these kinds of algorithms that are at scale, live, being used today. So the particular algorithm I'll tell you about is an algorithm that's going to be used and being used to predict which patients are going to have health needs in the future. The reason we want to do this is because a lot of health systems have invested heavily in what are called care coordination programs. So these are a little bit like almost VIP programs for patients that have a lot of health needs. So you get access to a specially trained provider, usually a nurse practitioner, that's on call for you and your needs. You have help in filling your prescription medications, in getting an appointment to see your doctor. And the idea is that if we can deliver to those very high-risk, high-need patients care when they need it, before their health needs deteriorate, not only will we deliver better quality care, but we'll also bend the cost curve and start reducing all of the in-hospital emergency care needs that these patients generate when their health needs aren't met in real time. Okay, so one key part of the program, which you might have already guessed, is that these are very high-touch, expensive programs. So this is, having a trained human on call for you whenever you need it. These things are expensive, and you can't do it for everyone. So you need to target these programs to the people who are going to need them the most. Makes sense. And this is a massive commercial market for algorithms. Pretty much every big healthcare analytics company, IBM Watson, et cetera, has a product in this space that's being sold and used by accountable care organizations and other healthcare systems today. So what we do is we obtain these predictions from a particular commercial algorithm. It's the largest algorithm in use today, but this is really representative of how the entire industry does this. And we get those data for a large primary care population. It's about 45,000 patients, fairly diverse. And what we get for that algorithm is we get the inputs that go into the algorithm, and then we get the algorithmic predictions that come out of it. And then we're able to do work looking at how those algorithmic outputs link to real outcomes, because we have those data linked to electronic health record data from the health system where these predictions are going to be used. So this is just some summary statistics about the patient population. I've broken it out by race, so for white and black patients separately, because there's one thing that we found very striking when we started evaluating how this algorithm worked in practice. And I'm going to show you data on the number of chronic medical conditions that patients have in this population. So here's what it looks like. So on the x-axis, and I apologize for the graphs. Yeah, I'm going to tell you about the axes now, but you can kind of tune out if that's not your thing. On the x-axis is the algorithm's prediction ordered from left to right in order of increasing risk. On the y-axis is the number of chronic medical conditions patients have at a given level of algorithmic prediction. And the two lines are showing you white patients versus black patients. And what you can see is that at any given threshold of algorithmic predictions, black patients have far worse health than white patients. So that's interesting because how are these predictions being used? Well, as I told you, they're being used to guide decisions about who gets into these programs that give you extra help and extra medications and extra appointments with your primary care physicians. So now you can imagine what's happening. At a given level of risk, white patients are healthier than black patients, but they're being treated the same way for the purposes of getting into this program that we think is very helpful. How consequential is that difference? You can perform a simulation exercise where you essentially swap patients in and out of the program until white and black patients have the same level of risk, like the lowest risk patient has the same level of health. And if you simulate addressing that inequality, you would actually double the fraction of black patients who are automatically enrolled in this program. So this is a fairly consequential level of bias that has the potential to impact real decisions in a very significant way. So I've been showing you these data, which is how many chronic medical conditions do patients have at any given level of algorithmic risk. You can basically do this for any measure of health. And we have a lot of different measures of health from the electronic health record data. This is blood pressure. So if you look at black versus white patients, these differences are, to scale them by mortality risk or heart attack risk, these are big, big differences. Hemoglobin A1C as a measure of diabetic control. Blacks have much higher levels. Lung function is worse. Red blood cell counts are lower, suggesting more severe anemia. Kidney function is worse. So pretty much any health measure that you look at a level of the algorithmic risk score, blacks have far worse health than whites, with the consequences that you can imagine in terms of getting into this program. So the obvious question is, of course, where is the algorithm going wrong? How is this bias creeping in? So there are lots of explanations. Glenn cited a few in terms of the training population and not extending to other diverse populations. I'm going to tell you about a very different mechanism. So one clue to what's going wrong here is where the algorithm is going right. So here's another graph. This is, again, algorithmic risk scores on the x-axis. But what I'm showing you on the y-axis here is the total medical expenditures of a given patient in next year's fiscal year. And you can see here there is zero bias. So the algorithm is predicting cost perfectly. And it's doing so perfectly for both blacks and whites. And so here's the problem with predicting costs. Black and white patients don't have the same relationship between health and health costs. So you can look at a level, and this holds for any measure of health. Now health is on the x-axis. So now if you draw a vertical line, you're looking at patients with the same level of health. You can see that the white patients have higher costs than the black patients. It's about 40% higher costs on average. This is because, of course, black and white patients have very different access to care. This is a commercially and Medicare insured population, but nonetheless, of course, there are so many ways in which black patients on average have less access to the healthcare system, less ability to take time off from work to get to their appointments, et cetera, et cetera. So what that means is that at any given level of health, blacks are costing less. So if your algorithm is in the business of predicting costs, you're going to build in all of the disparities of our healthcare system that affect Black patients into your algorithmic predictions. So that's the summary. The algorithm underpredicts risk for Black patients, and that leads to healthier whites getting into this program ahead of sicker Blacks. Of course, the proximal cause seems clear. It's the choice to predict cost rather than predicting some measure of health. But what's the distal cause? Why was that choice made? So there's one story that's, I think, on everyone's minds, which is incentives. So let's just follow the money and figure out why this decision was made. Of course, if you're a hospital, if you're an insurer, and if you're the analytics company selling a product to those hospitals and insurer, you care a lot about cost. But society cares about health. And so those are very different objectives. The choice of cost makes a lot of sense if you're an insurer or a healthcare provider. But for the rest of society, we actually care a lot about health, not just cost. And so you could view this as just another instance of profit distorting healthcare, which is something that we see a lot of. So that's one story. Here's another possible story that I want to at least have you guys consider, which is that we actually don't really know what we're doing when we build algorithms, and we're in the process of figuring that out. So under this story, you can actually go back and think about all of the discussions about healthcare policy that we often have. We often slip and use healthcare costs as a proxy for health. That makes sense because people who are sick generate costs. So, there's a certain face validity to that. But it's also convenient because it's hard to measure health. You saw how many different measures of health I had to put up to convince you that people were sicker or healthier. The same problem comes when you're trying to train an algorithm to predict something. It's a lot easier to use costs than try to come up with a very detailed, multidimensional measure of health. And so under this story, cost was chosen because it's convenient and because we didn't really appreciate that that choice was going to generate this enormous bias. So why does that distinction matter? Well, here's one reason why it might matter. After we saw these results, we decided to take what to many might seem like an obvious course of action, which was we just contacted the company that manufactures this algorithm. And we just said, hey, we found this problem. Did you guys know about this? And their answer was, oh my God, no, we did not know about this. They were incredibly responsive. They put us in touch with their research team that's building the algorithm. And they overall just wanted to work with us as academic researchers to understand this problem and to fix it. And so this has led to a collaboration with the manufacturer of this algorithm. They've replicated our results on the data set that they used to build the algorithm and found the same thing that we found in our hospital-based population. And together with them, we're developing methods to adjust those predictions and to build a new method of predicting that's free of bias. And just as a preliminary result, if you look at one measure of aggregate bias, so at a given level of health across the whole health distribution, how many excess chronic illnesses do Black patients have than white patients? Under the original algorithm predictions in their national population, there were about 50,000 of these. And when we've adjusted the algorithm in collaboration with them, there are now only about 8,000. So that's an 84% reduction in bias. And that was not by getting a new population, by doing anything very fancy with the statistical correction of the bias. We simply helped them to predict measures of health rather than measures of cost in their same data set. And so I'll wrap up by saying that algorithms will join many, many, many other black boxes in medicine, and that's okay. It doesn't have to be a problem as long as we follow the playbook that we already have for evaluating black boxes in medicine, and that's to look very carefully at the outputs from that black box without necessarily needing to open them. And I think that kind of scrutiny, yes, will reveal serious problems, including but not limited to bias, but these problems can be fixed. And I think that kind of approach will let us benefit from all of the great things that, as Glenn mentioned, algorithms can bring to us in our healthcare system and beyond, while avoiding some of these downside risks. Thanks.
Great. So in the remaining time we have, which is somewhere between 20 to 15 minutes, we are going to take questions from the audience. If you are interested in asking a question of either of our speakers or both of our speakers, we have a microphone in the center aisle. Please line up. But in the meantime, I am going to exercise moderator's prerogative to ask the first question of our speakers, which is, Zayed, in your presentation, you kind of go through how you caught a pretty important bias in an algorithm that was already being used to direct care for individuals. From both of your perspectives, what sort of regulations or process or norms do we need to put in place so that we can catch these mistakes and assumptions? Because Zayed, you can't be everywhere evaluating every single algorithm, I assume.
Yes, it's pretty clear from anyone to anyone who's worked with me that relying on me to do anything is not a good policy solution. I think, and I actually think Glenn is better placed to comment on this than I am, but I think taking our cue from how we approach the same problem from the point of view of pharmaceuticals, it's very clear to me that we need more randomized trials of algorithms because I think, as Glenn hinted at, when IBM is making up synthetic data to tell us that their algorithms are working well, it's not the kind of thing we'd accept in any other part of healthcare, right? If a pharmaceutical company told us like, oh yeah, we have a statistical model and our drugs are working great, that's not a substitute for doing the trial, nor should it be for algorithms. At the same time, I think we also from drugs have a precedent for what they call, I think, post-market surveillance, but essentially once the drug is out there and being used, our responsibility to evaluate it doesn't end. And I think that's the genre of things that, that I think we were trying to do. But yes, it's pretty clear that that shouldn't just be left to the initiative of academic researchers.
So I largely agree, but I want to add an asterisk or a caution or a concern, which is the following, is I think there's both culturally and pragmatically a lack of fit between FDA and Silicon Valley to some extent, right? Just in terms of the time frame for reviewing, the idea that these algorithms will form part of a learning healthcare system such that we want them to learn as we get more patient experience, we want to feed more data, we want to alter the algorithm as we go. So even if you're able to do the initial trial at approval, right, it would be strange to freeze the algorithm based on the data at approval when new data or stuff that Ziad learns shows us that it's having this effect in terms of race or in terms of other unexpected variables. And then the question becomes, will you go for reapproval, and at what point does that time frame and the costs of the approval process become problematic? So I do think that there's this interesting question. Now, having said all that, I think always in this area, we don't do it enough, we have to say, as against what? We have a strong status quo bias in favor of the way medicine is currently practiced, but everything we know about the way medicine is currently practiced tells us, no offense to my physician friends, right, but much of medical practice has very little evidence base in front of it. We don't know if it works, we don't know anything. So the question to me is whether you feel as though a more lenient regulatory process that let more algorithms through the door would sufficiently improve the delivery of healthcare as against the status quo, that you'd be willing to accept some of these risks. And that's just a very difficult question as a social planner. My own instinct is that it'll depend on what the algorithm is doing. For things that are offering patients more services or targeting people for more follow-up, I think we possibly can live with a less rigorous regulatory process. For things that are going to be denying people things or choosing what they get in terms of life-saving areas, perhaps we want more. But it's not just a conversation for the experts. You, as the patient population, have a right to make decisions and to participate in this conversation. So one question to ask yourself, if I could tell you, there's an algorithm I can apply that in 90% of cases would make care better, improve your outcomes, but in 10% of cases make it much worse. And you don't know ex ante which of the two populations you're in. Would you prefer to go with your doctor in the current baseline status quo, or would you rather your doctor be directed by such an algorithm? I think that's an interesting question to leave hanging.
Great. Questions from the audience? Please line up.
Hi. Jared Silverman. First, thank you for a wonderful presentation. Really eye-opening and so forth.
Just speaking in the mic if you don't mind, it's hard to hear you. Yep.
I'm interested in whether the mechanics of code writing, we understand how the data going in, may lead to good or bad results, sunshine versus problems. But do we also need to look at the mechanics of the code writing? In other words, is something lost in the translation when you apply it? I was wondering if you either thought of that, in your analysis. Thank you.
As anyone who's tried to read someone else's code knows, that is not a good way to catch problems with the code. So I think it's a really great question, because you would think we have the code, we know exactly the steps, but unfortunately these, even 4 lines of code, they stand in for such complexity in how you've created the data set, where the data are coming from, what the outcomes are, that it's very difficult to anticipate what the outputs of that code are going to be without seeing what the outputs are going to be.
Should we be doing more to try to understand that? I mean, to hold the algorithm makers more accountable, I guess, if we think that there is something lost.
Yeah, it's a good question. I mean, I think it depends on what your prior is about whether we have the cognitive hardware to understand what algorithms are doing. And I think that, I think these algorithms are generally more complex than we can understand. That's a good thing, because we want them to do things that we don't know how to do. That's a fantastic thing. So we wouldn't want to necessarily hamstring the algorithms by making them play by our cognitive rules.
I'll also add that a precondition of the work that Ziad does, and you'll correct me if I'm wrong, is some access to the verification set and some access, or the output set, and some access to the training set data. And there's no guarantee that we're going to live in a world where that's true, especially about the training set data. To the extent that this data is siloed and locked up as databases, that is part of the business model of the people who are making these algorithms, it may not always be possible to engage in this third-party scientific review of them. So one of the questions we have to ask ourselves is what our data policy will be as to these databases.
Thanks for that. So I think this is a follow-up on this last point that was made, but also perhaps mainly a question for Ziad. So it's a really nice example, and I see how it works quite well for the case of racial bias, because in the case of racial bias, you can sort of examine input-output patterns. We have this kind of heuristic. So if there's a kind of discrepancy between some groups that we already know how to identify, we know something has gone sort of normatively wrong earlier. There might be other kind of values that we want to scrutinize where we don't have these kind of easy heuristics. So I'm wondering what on both panelists you suggest we, yeah, I thought it might help.
Yeah. So I'll repeat the question. The question was, this is very easy to do the work, not easy, but this is admirable work you have done on racial biases, but there's lots of other biases in there that might be less close to the surface that we may not even be thinking about. Is that a fair paraphrase?
Thanks, man. Yeah, I think absolutely, and I think, the oncology example, I think, illustrates that, yes, there are some things we understand and we know to look for, but how is an algorithm going to affect downstream cancer diagnoses and misdiagnoses? That's not something that you can do in a post-algorithm audit kind of situation. That is a question that can only be answered with rigorous evaluation that are of the genre of randomized trials. And so to Glenn's point, I think for every use case, there's going to be a judgment call about whether we want to let these algorithms go into use without doing the trial. But I think right now, if you step back and look at the landscape in general, you find a lot of people, like no one's even thinking about doing trials, and I think that's a huge problem.
So because we have a lot of questions and we only have 10 minutes, what I'm going to do is implement lightning round rules. So if the next 2 people could ask your questions, and then the speakers will tackle whichever question they feel is appropriate.
I have a question on the liability with the vaccine. Professor Cohen told something about the allocation with the liability of vaccine, and I'd like to know a little bit more. Is there any criteria that the liability is allocated? What kind of internal process is they going through? And if there is interaction with external sources?
Great.
Thank you all for a very stimulating presentation. One question of predictive analytics back to the speakers. Given the tension, the growing tension between the data hunger required for advanced machine learning, especially unsupervised deep learning algorithms, and the increasing risk and suspicion about privacy and loss of privacy, I ask you all to either predict or even go so far as to what would you advocate in terms of the evolution of our privacy rules to balance that tension between data and privacy?
I'll take liability, you take privacy. Sticking with the hard one, right? But he's not a lawyer, so I mean, you want to take liability, you can do that too. So the bad news for my doctor friends is that they are currently on the hook and likely to be on the hook under the current case law about using AI-directed care. And the reason is because the doctor is the captain, or I don't know what the female of a captain is. I think it's still a captain. The captainess, the captain of the ship, right? And the idea here is that the expectation is whatever's helping you, whoever's advising you, you are making the final decisions. That is true in the current world we're living in. It's even true in the current world of AI implementation. One could imagine, though, a world where it's no longer true. If the insurer says the AI is recommending X, we will only pay for X, and the doctor really wants to do Y, is it fair for the doctor to have the liability in this case? And the truth of the matter is, in the US, most doctors are heavily medical malpractice insured to the point that, in fact, they never actually pay the money. They pay ahead of time, so we have a kind of social insurance plan. But doctors don't think about it that way. Malpractice haunts them in a way that economists might say it shouldn't. So I do think that there's some reason to re-examine the liability regime if we're moving to a world where physician choice is diminished.
Yeah, and I just to echo Glenn's point, I think no one is really seriously thinking about a world where there's full automation, where the decisions are made autonomously by algorithms. And so I think for the foreseeable future, much like in other areas like air travel, flying an airplane, the algorithms are helping the human, but the human is the captain. On the privacy front, I don't think I have a prescriptive statement, but maybe the way, at least I've found helpful to think about it, is what are the implicit tolerances and trade-offs that we're willing to make in other areas? So why am I willing to give Google access to my location? Well, because it helps me get around a city that I don't know, and it helps me forecast traffic. I'm getting something back, and so it's a bargain that it seems like we're very willing to make in a lot of other areas. But I think that's the same standard that we need to apply in this area. The greater the invasion of privacy, the greater the benefit needs to be to justify it. But I think if you just set any one person's opinions aside and thought about, like, in the world, how are people making this trade-off? I think that's how people are making it. It's, we're willing to give up more and more privacy as we get more and more benefits back from giving up that privacy.
All right, next two questions, please.
Great, thank you. Tony Weiss from Beth Israel Deaconess. This was great, and I appreciate you organizing this. I was wondering about the regulatory question that came up earlier and whether there's a light touch regulatory approach that could be borrowed from the medical publishing group. So when you think about current decision aids to physicians, in some ways that's the journals that we use to guide the behaviors that we implement within the hospital. And those are really overseen by peer review. And I was wondering whether there's an approach to algorithms that could be more, in a way, open sourced and peer reviewed to allow us to put some controls over that.
Hi, thank you so much, and thanks for opening this to the public. I'm wondering how data collection from patients in terms of Press-Ganey scores and patient satisfaction surveys, how that's influenced healthcare either for better or worse.
I really love the peer review idea, and if you, not to answer all of these questions the same way, but I think if you look at how the FDA asks pharmaceutical companies to submit applications, it actually kind of looks like that process. So the FDA has a very clear set of goalposts that, these are the data that you have to submit to get a new drug approved. Here's all of the boxes you need to check. And then a bunch of people at the FDA review those materials that are given in this structured way. And so I think I love the analogy to journal editing. I think it's a very good, you could imagine doing that as a first pass to say, okay, this is what will get the algorithm out there. Then we want some post-market, surveillance kind of thing. But I think it's a great idea.
I tend to agree, but I'll just throw again a little, clouds, you can't get away from it, but just to throw a little bit of clouds here, right, is to say, if the question is the who, then you may be right that peer reviewers would be just as good as FDA or someone like that. But if the question is the what is it that we're going to require to be reviewed? We come back to what I think are some of the fundamental difficulties here. The gold standard is the RCT done for the algorithm. We could require that and say, here's the who that's going to do that. But the question will be, I think, and this is something Ziad's thought deeply about, for certain algorithms, can you really make an evaluation without the RCT? And then to the extent you're also thinking that your algorithm is going to be implemented in a real workflow, in a real environment, we tend to think a molecular entity, right, a chemical, has the effects on the body for the most part pretty homogeneously however it's administered. An AI and the way it's administered and the way it interacts with the style of practicing medicine, with the way a hospital is run, with an insurance system, there's likely to be a lot more variability. So even as to RCTs, you might think the results of the RCTs are less probative for other implementations, and especially if you think function creep tends to happen with these AIs. So the who partially may solve the problem, but the what may still get us in the end.
Yeah, and I'd say that the reason that we insist on randomized trials for drugs is because there are very real statistical problems with generalizing from observational data. Nothing about machine learning solves those problems. Those problems are just as vexing with machine learning as they are in any other applications. And so, the idea that we can say, okay, I've fit an algorithm to predict the results of testing among the people who got tests. Now I'm going to apply that to people who never got tests. Those people are very different. The doctor chose to test these people for a reason. They're very different in both ways that we measure and ways that we don't measure. So it is not, until you've, you don't get the benefit of the doubt. The assumption is that that's not going to transfer over to the untested people until you've shown otherwise.
And on the patient satisfaction score, so my brother likes this book, Who Moved the Cheese, about, it's like a business book or something like that, right? When patient satisfaction is the cheese, as was part of the rollout of part of the ACA, people chase the cheese, right? You would then kind of orient your thing like that. Now what we saw, I don't know what your opinion is, what we saw with an overimportance of patient satisfaction scores were investments sometimes made to improve patient satisfaction that didn't necessarily improve health or kind of against it. Now, it is normatively possible to have the view that healthcare is in part a consumption good, and just like I like driving a Tesla more than something else, I've never owned a car, but just someone might enjoy driving a Tesla more than a Maserati, I don't know who they are, that's fine, let's just take that value neutral and give it to them. But I think most of us view healthcare as having goals and measurements that are not directly connected to patient satisfaction. In some ways, the doctor doesn't give you an injection so it didn't hurt, and instead you get the lollipop. That's not a happy outcome. That means you are unvaccinated and are infecting other people.
All right, last two questions.
Glenn, you brought in your clouds, the consent piece, and the urgency perhaps of dynamic consent in the world that we're moving through with AI. In the absence of having something like GENA, which protects us from misuse of our genetic information, how urgent do you think for new legislation might be for how we think about the use of our artificially intelligence-derived predictive values of our health risk?
Hi, thank you for this conference. I'm both thrilled and terrified at the same time. I'm wondering if anyone in this arena is thinking about the interaction between electric health record input, data input, and what the algorithms are being built on. Because we know EHRs have changed behavior, they've changed documentation, we tend to be metric driven now, so everything changes for the metric. And I could see if you're using over a couple of years for your data, it could shift over time. And the EHRs, they're big, powerful companies. They're not going to do whatever you want.
Actually, the first one was, remind me the one word of the first one. This is the problem with two questions.
Well, dynamic consent
Perfect.
and Gina.
And Gina, yeah, so I'm actually working on a paper with somebody in the audience right now on looking at long-term care insurance and life insurance, where in fact our existing protection, Gina, the Genetic Information Non-Discrimination Act, does not protect people against adverse inferences based on their genetic data. But the reality is we're moving to a world where our ability to make actuarial guesses about your needs is much higher than it was before. Now, there's a positive side of this if you believe in actuarial fairness, which is to say, why just penalize you if you're a smoker versus not? Why not penalize you for or reward you for many more things about you that gets the fairness more accurate? But the flip side is that insurance to function has always been a socialized market. If we could perfectly risk stratify everyone, we'd have no insurance because everybody would just buy at the level of their risk is. I do think, and this goes a little bit back to the question about privacy we were asked before, there is a division between people who are much more focused on upstream protection and people who are more focused on downstream protection. The upstream people want to limit the amount of data you can collect about people. The downstream people, and you can be concerned with both, want to say, we're not so worried about the data collection, we're worried about particularly nauseous uses of it. And let's focus on beefing up the anti-discrimination protections. I'm probably a little bit more in the second camp than in the first, but there's other people who say that's a fool's errand because the way in which lobbying works and Congress works, and the fact that when the Republicans were in control, they wanted to actually repeal parts of GINA, not extend it, makes you think that actually relying on Congress or legislation to protect us against this kind of actuarial discrimination might be a fool's errand.
I'll just say one thing on the second question. So I think it's an uncontroversial statement to say that there's a lot of garbage in the electronic health record. I think there's also a lot of gold, and I think there's it's just like all of medicine and all of healthcare. It's there's both, and so here's one crisp way to think about the distinction. If I train an algorithm to predict a variable that has a lot of bias built into it, for example, cost, even, for example, the doctor's decision whom to test, we know that there's not just bias, but there's error. There's just a lot of mistakes in that decision. So you can contrast that with saying, okay, what health outcome did that patient ultimately have? Now, there's still biases built into that, but that's at least a way for the algorithm to learn not from doctors' decision-making, which is error-prone and biased, but to learn from real outcomes. And so I think the more we can get algorithms to learn from nature, from real patient outcomes, and not from, not just mimicking what decisions doctors are making today, the better the algorithms will be. And I think we have both of those things in the EHR, and that's why we have so much crap coming out of the EHR and algorithms built on that. But it's also why I'm fundamentally very optimistic that done the right way, we can have algorithms that give us the best things that we collect in the medical system.
So I'm cognizant of time, but we've only taken 5 more minutes of your life than we initially asked for. Please join me in thanking our 2 great speakers for today.